Today, in Contextual Point, I'm going to talk about pharmacotherapies for osteoporosis, which is assessed for many times in step 2 and step 1. So let's get started. Firstly, we have 5 different options to use, but the only and main important option we have is bisphosphonates. This is first line, and we use other drugs if there's a contraindication about bisphosphonates or bisphosphonates are not working well. So the alternatives are denosumab, teriparatide, SERMs, nasal calcitonin. Bisphosphonates are drugs that inhibit osteoclasts. So that means when we inhibit osteoclasts, this will cause reduced bone resorption because osteoclasts are cells that resorbs bone. This is a straightforward mechanism. And bisphosphonates could cause esophagitis and even esophageal cancer. So we need to advise the patients that to take with this drug with a good amount of water and an hour before food and other medications. That it is because it could affect resorption of other medications, which is really important in step 2 settings. And prolonged use associated with atypical fractures. I really give an advice to note that one too. And caution in renal impairment. So we cannot use bisphosphonates in reduced GFR and chronic kidney diseases. And oral and IV options available. And you may want to know that flu-like symptoms could be seen after IV administration. After our first line drug, we can talk about other drugs we have. So the other one is denosumab. And when you see something like mAb inside of its name, it's a monoclonal antibody. So denosumab is a monoclonal antibody against RUNC ligands. So denosumab mimics osteoprotegrin. So because it mimics osteoprotegrin, it targets RUNC ligand. So that's why we call this a monoclonal antibody against RUNC ligand, and it further decreases osteoclast activity. So if you want to illustrate that, so let's see, this is osteoclast, and osteoclasts have RUNC on its surface. And a RUNC ligand, if come here and bind to RUNC, it will activate this osteoclast and it will lead bone resorption. But if an osteoprotegrin comes and binds to the RUNC, it will block to binding of RUNC ligand to here. So osteoprotegrin will block the RUNC ligand binding to RUNC. So it will cause to decreasing activity of osteoclasts because of that. So that's why denosumab, which is a mimicking agent of osteoprotegrin, as in here, will decrease osteoclast activity because it is a molecule like osteoprotegrin. So we can also say denosumab. Okay. And we can use denosumab if a patient has renal impairment. So as we said, we cannot give bisphosphonates, or also bisphosphonates are not worked well. And we may note that skin reactions and infection could be seen with denosumab. Okay. And other one is teriparatide. Teriparatide is a parathormone analog. So if you know it's a parathormone analog, you can learn everything. It is a parathormone analog. So teriparatide increases the activity of osteoblasts and it leads hypercalcemia. So it should make sense because it's a parathormone analog, and it increases risk of osteosarcoma. It should also make sense because it's a parathormone analog, yeah, and it contraindicated in Paget disease of bone, and also unexplained high levels of ALP and history of radiation therapy. This could be more important in step 1 settings, but also in step 2 too. And Paget disease of bone is really important. And SERMs. These are selective estrogen receptor modulator drugs, but especially we use raloxifene in osteoporosis. Raloxifene is a type of selective estrogen receptor modulator, but it is agonist at bone, but antagonist at breasts and uterus, so it makes sense. It is agonist at bone, this is why we use that. But also, because it is antagonist at breast and uterus, we use this drug for patients who have osteoporosis, but also concomitant breast cancer or increased breast cancer risk. This should make sense if you know what raloxifene does. But please remember that it increases DVT because it is a SERM. It's straightforward. And the last one is nasal calcitonin. It is least effective and used in only rare circumstances. You may only see it in choices. So yeah. And the last slide is sometimes you only need to stop a medication rather than giving a medication for osteoporosis. So please don't remember that glucocorticoids are causing osteoporosis. This is really, really high yield in step 2 and step 1. So the other ones are a little bit too low yield, but I just put in here for completion sickness. If you want to get 280 or step 2 or step 1, and you cannot get any score from step 1 though, but opioids are causing osteoporosis. This is interesting because opioids are suppressing GnRH. And also thiazolidinones. You may see some questions if you're unlucky in your step 1 examination. Thiazolidinones also cause osteoporosis. And zinc, because zinc competes with copper and it will lead less absorption of copper, and it definitely causes copper deficiency, and copper deficiency could manifest as osteoporosis. These are low yield, but glucocorticoids are high yield, and you will definitely face a question about that. So that's it. If you like this video, please subscribe my channel, and I wish you a great examination date.